So today is a special ground rounds. This is the first time that we have launched our Psychology Innovation Awards. And so these are the inaugural lectures from our two winners of our first year. We have a research award and a clinical award. And Barbara and I and our PACs are going to release the next call for nominations in July. So please be thinking of who you want to nominate. That's right. Self-nominations are great, and we just have so many stellar candidates. So we just encourage you to keep applying. We were blown away by the strength of all the applications. Okay, so it is my distinct pleasure to introduce Sasha Gorrell this morning. She is a superstar, and she's only been in our department 3 years. And both of our awardees were from the eating disorders program this year. So it's, you know, what I call small and mighty. We just have really stellar clinical and research work from this clinic. Sasha is a licensed psychologist who treats adolescents with restrictive eating disorders, in specifically supporting recovery in family-based treatment. She received her BA from Columbia, master's from NYU, and her PhD in clinical psychology from SUNY Albany. Following a T32 postdoc in clinical services research, she joined our faculty in 2021. Her research is funded by NIMH and the Brain and Behavior Research Foundation, with a focus on characterizing shared features of anxiety and eating disorders and using this knowledge to adapt and develop novel evidence-based treatments. We'll get to hear more about today. In addition, Sasha spent her previous 8 years before her esteemed psychology, clinical and research career as a professional ballet dancer. She was with the Boston Ballet and the American Ballet Theater, and these inform her current efforts to support the well-being of dancers and athletes across all career stages. Sasha, your commitment to treating adolescents with eating disorders and your innovation in both the mechanistic etiology of eating disorders, as well as applying this to novel treatment pathways, is truly inspiring and really exemplify the spirit of this award. Thank you so much for your great work.
Good morning. Thank you, Alyssa, for that lovely introduction. Today, I'll be talking about some creative solutions to address both treatment efficacy and access. I'm hoping to use some examples from my own work, overcoming some challenges, to potentially inspire you. Beginning with some acknowledgements, my funding, my disclosures, the land that I live and work on, and the top right there, I could not do the work I do without my fantastic eating disorders program team. 2 of my mentors from my K-23, and at the bottom there, 3 research coordinators who really allow me to do all of the research that you're going to be hearing about today. I would be remiss to not, first of all, thank the department for this award. Thank you so much. It's such an honor, but it's also a real honor to be presenting here with Dr. Erin Riley. Erin and I went to graduate school together, and so this is actually truly a photo from a decade ago. We've been working together since. You can tell that Dr. Riley has not changed very much. It's been just such a pleasure to not only have her as an esteemed colleague that I deeply respect, but also as a good friend. So it's exciting to share this podium with you. I'm going to be making a case today that science is actually a creative art. So there on the left is, as Alyssa mentioned, is actually not an 8-year career, it was an 18-year career. I was there at the base of the Manhattan Bridge doing some creative work in my prior iteration. On the right there is a photo credit to my spouse. I think if this had a title, it would be Wife in Natural Habitat. The juxtaposition of these 2 sort of identities that I've had in my former career and my current career, I think there's less of a difference in my mind between the 2. I find the work that I do on a daily basis deeply creative, and I'm hoping that you will sort of get that gist from what I'll be talking about today. What am I talking about? First of all, making a case that eating disorders is sort of a useful example for all of you. Those of you who do not work in this field, hopefully you'll be a little bit more convinced. I'll be talking about some of the theoretical foundations for where I start with when I'm trying to solve some problems. And then, as I mentioned, some creative solutions. Hang on, there's going to be a lot of material. I'm going to be talking fast, throwing stuff at you. Part one. There are super high rates of comorbidity. I think we tend to think of some of the work that we do in our clinical work and in our research as being siloed. I'd say that most people in this field who work with eating disorders would say that it's rare to have somebody who actually only has a diagnosis of an eating disorder. It's much more commonly you see these comorbidities, particularly the ones highlighted in blue, obsessive compulsive disorder and related anxiety disorders. I'll be talking today a lot about anorexia nervosa, as it's a diagnosis that I tend to spend a lot of my time thinking and working with. For those folks, sometimes the rates of depression, it's hard to tell whether it's a secondary to malnutrition or premorbid. The rates of anxiety that you see there is, social anxiety disorder and generalized anxiety disorder specifically. I would say that those are actually a little bit low. This is from the literature, but I think from our personal experience here in the clinic, we do really have a complexity in this that I think extends to all the work that we do throughout the department. This is one of my more favorite figures. If you zone in right there on the bottom, sort of the middle adolescence, age 15, it's a striking peak of when eating disorder onsets. This is on a population level. And I think just thinking about even within the work that you do personally and your specialty and your content, if we were to survey our entire department, which I've been told that we have some surveys coming out potentially soon, both on the adult division and the child division, I wouldn't be surprised if you're going to see actually more eating disorder pathology within other diagnoses as just being secondary. There's low efficacy and low reach in the work that we do. And I know Aaron will be talking a lot about this in just a few minutes. So just to briefly say that only about 60% of adolescents respond with a full remission following our first line treatment. And even more notably, it's a little bit striking that there's actually no current evidence-based treatment that's recommended for adults with anorexia nervosa. So there's a sense of urgency, a feeling of we need to do better, but where do we start? So thinking about, as we are good scientists, where do we start? Usually with thinking some of the sort of theoretical foundations of the work that we do. Love me a good forest plot. This is polygenic risk for OCD, and the eating disorders at the top right there is pretty striking in terms of how sort of striking the positive correlation is. But I would say even more notable if you zone into what's on the middle on the left, the purple dots, and then the ones that are just below it, those are actually more physical features. So insulin resistance, weight status. So this is something where some of the work in this field in genetics has been looking at anorexia nervosa as potentially a metabo-psychiatric disorder. They may be thinking about this more as not only in a psychiatric zone, but also maybe with the physical sort of components of it. So thinking about this is, a harbinger potentially in the next decade or so of some interesting work that might be more of a mind-body connection rather than simply just thinking about it as a psychiatric disorder. Zooming even further out into some of the foundational neurobiological models, most of the work has been focused on reward dysregulation as well as habit formation. About 10 years ago or so in Change, Timothy Walsh at Columbia proposed this habit hypothesis of anorexia nervosa, such that when behaviors were first onsetting in the context of eating disorders, potentially they were more reward-based. Over time, they became more habitual and entrenched. Similarly, Dr. Guido Frank at UCSD has a more recent updated model of this, but it centers on sort of more of a top-down from the cortical to the striatal. So it's sort of similar, even though it's a little bit more developed in terms of adding a fear component. Dr. Walter Kay at UCSD as well, who's recently retired, although he's one of those researchers who probably will never actually retire. Just from the title alone of this formidable work that he's been doing throughout his entire career, you can kind of see that he's still also centering around this reward component, how the features of the disorder are really sometimes ego-syntonic for a lot of people, especially at the outset. Interestingly, those of you who are more in the animal model realm, this is some work by Jeff Beeler, which is in preclinical models. The rise and fall of dopamine is what he's proposing here as sort of an extension of the rodent work to humans. On the left-hand panel there, you can see that as the behavior is onsetting, it seems to be really dopamine mediated. that the behaviors are reinforced positively, but over time, as you zone into the right-hand panel there, it's almost like there's a degradation or a desensitization of dopamine function, and that these behaviors become more rigid and inflexible over time. So again, throughout species level work, whether it's preclinical or in the human model, we do know that it seems like reward is implicated and habit is implicated. And yet we don't actually have a lot of neurobiologically based treatments at this point. There are a lot of reasons for that. One reason is that anorexia nervosa, as we might imagine, is complicated by malnutrition. You know, there's a lot of things that we could say, is this only because this person is actually working with a brain that's, you know, deprived of glucose? Bottom line, there's a lot of other reasons, which I could spend a whole other half an hour talking about, why we don't actually have a lot of interventional psychiatry, but we are at this point as a field really behind the curve. You might say that's disheartening. I think for me personally, I get really excited about it. I see sort of this very high approach behavior as we have a mountain of work to do, and I'm really pumped to do it. There's no clear path forward though. Cat owners, you might be familiar with the Amazon phenomenon. Cats spend a lot of time working inside of boxes, but I would propose that it's actually time for all of us to start thinking outside of the box, moving into these creative solutions as promised. As one does when one is thinking about how to define creativity, one asks ChatGPT. So at the top there, you see what ChatGPT first delivered for me. I really didn't like that for this context, so I said, can you provide me with something more succinct? And I got what was the last line there, which I think is actually pretty good: producing original and valuable ideas by thinking in novel ways. Let's get right to it. There are 3 studies, or domains rather, that I'll be talking about today, starting with the potential of in-lab research. This is a piece that I wrote a few years ago that was really asking for a pivot from what we typically do in this field is a lot of self-report, getting sort of more pencil and paper reports. And so it was a sort of call to arms, call to action of let's do some of this work in the lab. There's been a long history of maybe not doing this so much because of the medical acuity of this population, also sort of the belief that some of the disorder onset was because of more family-related factors. We've moved into a realm now where it's much more commonly to think about these as neurobiological, as more translational and more mechanistic. This was a paper that I actually was sort of like driving into with driven exercise, and fast forward a couple of years now, we're doing an in-lab study here at the Pritzker building. We're making milkshakes, we're drawing blood, we have people on exercise bikes. Don't worry, none of these people are actually participants. They're all research coordinators who are helping to launch the study. This is a pilot study that I've been working with Dr. Catherine Schomburg at University of Wisconsin-Madison. If you're paying attention, she was also in that 2015 photo. Always write grants with your friends. This is some of the pilot data that supported this study that we're running now in the Pritzker. As you can see, 37 people, it was roughly 20 and 20 females with restrictive eating disorders and controls. The orange color there is supposed to be controls, but you don't see a lot of orange there. You just see the effects really in the control, the eating disorder group. Across every one of these panels, they're in reference to a change in body image following a 30-minute bout on an exercise bike. And this was only found, that shift in body image improvement among those with eating disorders, and there was really no effect at all for controls. This is a small study. We're not presenting p-values, it's just D's, Cohen's effect sizes, but I think you can see that there really does seem to be some notable shift in body image for this population. We also, as I was mentioning, are collecting some blood-based biomarker samples. I think, again, some of the small sample could be driven by outliers, but I think it's pretty striking that the directionality of effects, the valence, seem to be really group-based in opposite directions. So BDNF there, you can see, seems to have a steep increase, where control seems to have a decrease. On the right-hand side, I was particularly intrigued with this finding, where at the bottom there, you see basically no effect at all from the effect of exercise on the eating disorder group, where you do see the rise in cortisol, sort of implying that this group might have more stimulus or anxiety reaction to the exercise itself. Again, we're still collecting data. These are preliminary effects, but I think just sort of compelling. Generalizability to real world behavior. You know, we do a lot of this work in lab, thinking about, does this actually reflect what happens in the wild? This is a progressive ratio task. On the left-hand panel there, you see that the folks in the blue with eating disorders were more willing to work for exercise as a reward. And they, on the right-hand side, were less willing to work than controls for a money reward. So again, this is just a behavioral task in lab, but thinking about just their effort that they're willing to put into something if they know they have an exercise reward. Notably, both of these groups actually had a similar amount of outside of the lab exercise. We have accelerometers on them, and they are pretty much the same fitness level. So they really are actually motivated to work for exercise. Some takeaways from this work. Having experimental control with executive measures really does actually boost the power of your pilot data. I know that's sort of a given, but I think for me, my whole life just collecting, you know, sort of like I was mentioning, more of these self-report measures, I think just the quality of the signal here just feels somehow meaningful, interesting, gets me really excited to do more. I wasn't really sure if we were going to be able to pull off a 3-session, pretty intensive assessment study where multiple hours, people actually are coming in, we're recruiting at pace. We're even kind of having people enjoy it. So I think it's something where I was skeptical. We're not even paying them that much, but we are actually getting people in here to do this kind of intensive in-lab control stuff. And then finally, I think, as I was mentioning, like we have such a sort of association with in-lab activities as being very tightly controlled. But what we found is with correlating them with those self-report measures, we're finding a lot of really interesting extensions to what happens out in the real world. Moving into the second domain here. Some of you might be working with entities who are a little bit less willing to have you come in and study them. As I mentioned for myself, there's yours truly in the middle there. I was part of one of those entities where they don't really actually like anybody coming in for a lot of reasons, right? They're professional athletes. With that said, I have a really strong interest in eating disorders in dance. Why is that? Well, for one, dancers have a much higher risk of eating disorders than compared to the natural population. They're also, in some cases, at 80% plus of having a lifetime experience of an eating disorder. In my own work, I found almost 40% at a low weight, which is to be expected, you might think, but there's also about 11% of them who actually would have met criteria for a clinical eating disorder had they actually been assessed more formally. If they are somewhat resistant, they're not going to necessarily come into me for treatment. This is something where I think I've spent a lot of time sort of wrestling with this. Is it better to maybe focus my efforts and attention on primary prevention rather than expecting them to come to me? And so that's exactly what I did. This is a project which I've referred to as the Athlete Body Project. Some of you might be familiar with the Body Project, which is a nationwide and beyond eating disorder prevention program. For my dissertation, way back in the day, I modified this intervention for use in dancers specifically because I had that experience of knowing what the terminology was and how to relate to the dancers. I used to dance with the director of San Francisco Ballet School, and I used to dance with the director of Australian Ballet. And so that gave me a great foot in the door to basically cold call them and say, can I do this stuff? It is a 3-session intervention, so low participant burden last winter. The programming was required as part of the educational activities in these schools. It was only the research component where they agreed to let me have them do pre-post surveys. It is a manualized intervention. I adapted it from use in adults down to adolescents. We also, when we were in the process of planning, all of the institutions that I was working with and talking with about this said, well, what about the boys? Because it was originally just done for girls. And so modified it for boys. As much as I would have loved to go to Australia for a couple of weeks and do this intervention, we also adapted it for Zoom to make sure that it was something functional. So kind of a proof of concept. Can we do this in younger people? Can we do this in athletes? Can we do this on Zoom? Lots of questions. The content, it's, as I said, very brief, so not a lot of material. It's how we think about our bodies, how we talk about our bodies, setting goals around sleep and other health behaviors, improving overall well-being, how to be the best athletes we can be, and building tools for psychological resilience by setting goals in small groups with one another to hold ourselves accountable. How did it go? Well, you can read the paper if you're interested. If you look at sort of the colored features that I have there, the directionality is important in terms of eating disorder pathology in blue went down for the most part, in green body appreciation went up for the most part, and drive from muscularity went down. And so all these things, again, pre-post and then at 8 weeks seem to be showing sort of that signal that we're hopeful for. What I got kind of tickled about though was the qualitative stuff. I mean, I didn't ask for the heart emoji, but there you go. And it's like this, I think for the most part, the only thing the kids really didn't like, and this was across both institutions, across Zoom or in person, is that they just felt like it was too late at night. They wanted it during the day where they weren't tired. So I think that that was really important information for me to know, that I saw the stuff that I wanted to see clinically, but they were also in some ways benefiting in ways that I didn't even know. Takeaways. If you're doing work with people who are potentially resistant to having you come in and work with them, make it required as part of whatever you can figure out. So education, whatever it is, slip it in there, and then have the research part of it be optional. I know it's a little ironic that I have this statement here, because I just finished in my last segment telling you if you pay them, they will come. Well, in this case, I felt like I had to go to them. I was the squeakiest of wheels. I basically begged them to let me do it. I was there late at night, on the, in the morning, on the weekends. I was extremely flexible, pun intended, touching my toes whenever I could to make sure that I was there, ready for it whenever they would let me do it. Collect the qualitative data. That was something where I said I kind of did on a whim, but what ended up happening was I had a bunch of sound bites then that I could go back to the administration and say, hey, look, they loved it. It's important. We need to do this again. And so it was something that just helped to bolster my ability to, once I was in the door, to kind of keep myself in there. So stay tuned, still working on it. My third paradigm, reassigning a paradigm from an existing sort of protocol to something that's in a new population. Neuromodulation for eating disorders. Is it a good idea? Well, it's FDA approved for folks with major depressive disorder and OCD. This is a piece that I wrote with Dr. Amanda Downey recently, where we're talking about innovative and emerging treatments. Turns out that this is one of them that is generally not commonplace in the United States. Much more of this work is being done overseas and in Canada, but something where we're really making some strides in this. A lot of benefits potentially in terms of global effects. I do feel strongly that this should maybe not be a replacement for eating disorder treatment, but definitely adjunctive, something to add on. As I mentioned way back when in the beginning of this talk, that there's a lot of comorbidity, and folks that maybe would be benefiting from an antidepressant effect or reducing some OCD behaviors as well might feel that this is something that extends beyond even treating their eating disorder. This is a figure from a review on OCD. And I think this is just something where I've been applying this model from OCD, sort of a neurocognitive pathway potentially, from sort of a top down, maybe orbital frontal to striatal. And this is something where I think if you sort of think about, could we use the same framework for anorexia nervosa? That was the basis from some pilot data that Moses Lee and I started with. This is from a single patient who had severe and enduring anorexia. She'd been ill for over 15 years of her life. She also has comorbid MDD and OCD. And so it was something where we were really struck by some of the findings just from this one patient. So in the panel B there, you see that actually pre-TMS to post-TMS, using the orbital frontal cortex as our target, we found that connectivity increased in that top-down, sort of the frontal cortex to the striatum. And so that was something where the directionality was perplexing, but we saw a difference. But I think even more interesting was looking at sort of that bottom panel. The mechanism of action actually seems more canonical, maybe more network related. And so in the bottom there, you can see an uncoupling between the default mode network and other canonical networks like limbic and salience and attention. It's almost like our networks are supposed to be naturally pulled apart. In this case, pre-TMS, this patient was experiencing some sort of like tangling, if you will, between those networks, and it seemed to pull apart in a way that was adaptive following TMS. This inspired an open trial. We have the same target of the right frontal frontal polar orbital frontal cortex. Moses and I have, sorry, the formatting's off there. We've treated 7 so far with relatively good retention and acceptability. We have 4 with 1 month data, which is our primary outcome. Importantly, though, there's 2 things that are really different about this. One is our treatment approach. So using TBS instead of a normal course of TMS, which is much more condensed, it's much more intensive. We also are using a relatively new target. Most of the work in this field with eating disorders has been the dorsal lateral prefrontal cortex. There's a tiny bit in dorsal medial prefrontal cortex, but using the orbital frontal cortex is entirely new for eating disorders, kind of applying that OCD paradigm into anorexia nervosa. Really exciting. On the left in the panel, the A, you can see that in that 1 month primary outcome, all 4 of the people that we have that data for showed a decrease in their eating pathology. On the right-hand panel there in panel B, pre-post TMS, you can see actually intra-network connectivity reduced in the default mode network. So again, something that might be indicating something more canonical and not necessarily specific to a region of interest. So stay tuned, we're still collecting data and very excited about it. This, as I mentioned, as a takeaway, has given me some new ways of thinking about the etiological models. Yes, it might be reward-based, it might be habit-based, but maybe it is also something that we can look more towards what's been sort of established in OCD to think about applying to anorexia nervosa as well. As I mentioned, the global effects, everybody in the study that has had sort of comorbid depression, comorbid OCD, has mentioned that they just feel lighter. One of the patients very strikingly said, you know, my friends tell me that I'm like a much better person. I'm just much more relaxed, which I think you could think about for all of our patients as kind of a benefit. And then lastly, we were improving treatment access. You know, our clinic here treats only up to age 26. And so in this particular open trial, we were able to treat a patient who was 69 years old. And it feels really meaningful to have that ability to treat across the lifespan with something where I mentioned earlier, there are no proven evidence-based treatments right now for this disorder. So thank you so much for your time. Thank you for indulging me with my argument that maybe the work that I am doing in terms of solving my own problems with creativity could be inspiring for you. This is a quote by Maya Angelou, the more you have, the more you have. So thank you very much.